Next on call, allergy shots,
left arm first for the pollens. That's 0.5.
dust mites, and understanding allergies.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Whoa, hard. Whoa, whoa, whoa. Keep pushing.
Just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. Allergies are complicated. If you want to read up on why your sinuses ache when pollen counts go up, or why peanuts trigger an allergic reaction in your grandchild, get out the medical dictionary. Immunoglobulin E, T lymphocytes, H1 receptor blockers, these are all terms that you're going to come across when you research allergies, and it may take a little time and effort to understand these things. Well, we hope to simplify that process tonight. Here in the studio, we have the physicians on hand. They're ready to answer your questions about allergies and help you gain a better understanding of how your immune system responds to things like cat dander and ragweed. Joining me live, ready to answer your questions, are Dr. Thomas Luzier and the On Call medical editor, Dr. Rick Holm. The phone number for you to call is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. And helping the phones tonight are volunteers from the Brookings Health System Auxiliary. Dr. Holm, before you introduce our guest, what kind of allergies are you seeing in the clinic in your patients right now, this time of year?
People are coming in with a cough that's 4 weeks, 5 weeks, 6 weeks, 7 weeks old. I've got a cold. It just won't let go of me. And the answer is it's not a cold, it's an allergy. And I'm just seeing it. It's just a lot of this nasal drainage that persists. I've just got a cough. And that's the most common thing. I mean, I'm seeing it, I saw several today. I've seen this week, 4 or 5. I mean, and you know, my practice is all these other things too, but I'm just seeing this right now. Well, it'll be interesting to hear what our guest, of course, he's an allergist, so
yeah, let's find out more.
We'll find more about that. I'm very pleased to introduce to you our guest for this evening. No stranger to this television camera, Dr. Tom Luzier from Aberdeen Asthma and Allergy. Welcome, Tom.
Thank you very much. And I'd like to comment on just what you said about seeing all these colds that don't resolve.
Yeah.
And we have this interesting phenomenon in April in South Dakota where we have a collision of the viral illnesses, which are just going to start winding down as summer comes along, clashing with our allergic disease, both of them very immune related. So that viral illness in an allergic patient kind of triggers or upregulates the system, so they're a little more sensitive to their pollen. Tree pollen is what's out right now. And of course, under that snow, you did have snow down here, didn't you?
Yes, we had plenty of it. Did you have it up there in Aberdeen?
Third snowiest year, yeah. You know, I became an expert in snow removal. And underneath that is the mold that forms as a part of that moisture. We call it snow mold.
That's that white stuff,
and we need
right?
to talk about snow mold a little bit more, but keep going.
So we have these two factors that are apparent in our outdoor environment. And of course, what happens is that snow mold dries up and gets windborne, as we know on our very few warm, windy days. And so it really propels it. And then if you really want to add something to it, everybody wants to mow their lawn on the same day.
Yeah.
And so, and so all that mold goes up into the air. So our mold allergic patients come to your office and they're not always sneezing. You know, sneezing's kind of a pollen thing. Mold is kind of a, I breathe it in, I do fine, I'm a little stuffy, I get in the house that night, and oh man, I can't breathe at all, and I can't sleep at night.
So it's different. Very, very quickly, because we're almost out of time for this segment, but you're an allergist, but what else are you? You've been trained first as a...
Well, I actually started out in OBGYN, but I went to pediatrics, and that's what I got board certified in. And I had a big interest in neonatology, but because I was an allergic person, and I could see how much help you could do for a very common problem, I became an allergist.
Great. Well, we will challenge you to give us your allergy questions. We've got the expert. We'll be back right after this.
In 2007, approximately 3 million children under age 18 were reported to have food or digestive allergy in the previous 12 months.
It's always a little disconcerting to face the fact that we live our lives with bacteria and viruses and bugs all around us. And there's a microscopic creature called a dust mite that might be sharing your home with you right now. Aggravating allergy and asthma symptoms. We interviewed a South Dakota State University professor who is the curator of a vast library of insect samples known as the Severin McDaniel Insect Research Collection, and we asked him about dust mites.
In the traditional way. These are some North American species here.
Professor Paul Johnson is an expert on bugs. He knows where they live, what they feed on, and how to precisely identify what they actually are. And he says, in the case of dust mites,
they're mites, and so they're small little creatures that are related to chiggers, related to ticks, and more distantly related to spiders. So they're not insects at all. They're eight-legged little critters.
It takes a strong microscope to get this good of a look at a dust mite. Generally, they're less than 0.5 millimeter long, and you won't be able to see whether or not they're sharing your home with you.
They tend to be more abundant in bedroom situations and in carpeted situations. They're feeding on organic matter, the dust that accumulates in fabrics, in carpeting. So that can include anywhere that you have not only food particles collecting, but dander, skin pieces, fragments of hair, open, airy fabrics such as carpeting or loose linens tend to be really good places for dust mites to accumulate if they're not cleaned regularly.
Johnson can tell whether or not a bug will bite and feed on humans, and he says, in this regard, dust mites aren't much of a threat. Most allergic symptoms due to dust mites are caused by inhaling or somehow becoming exposed to proteins that are found within the dust mite body.
It's a combination of bites and exposure to the dead mite bodies, the fragments that we would breathe in or come into contact with on the skin. And that's where the cleaning, the things like shampooing carpets periodically or washing the linens comes in handy. So you're removing those mite parts. They do bite, or they will, make temporary bite attempts, but they're really not feeding on you. It's more a matter of, they're just testing you out. There are no general use pesticides, for example, that are recommended for these. This is more a matter of managing the habitat, and in the case of a home, a reasonable effort at keeping the home clean. Frequent vacuuming, periodic shampooing if you're talking about carpets, making sure you're getting down along the corners and the edges there. It's really a lot of just normal cleaning of the house.
Doctors, my understanding is that actually because of how dry it gets in South Dakota homes during the winter, that we don't have to worry about dust mites that much because it's just too dry for them to reproduce. Is that correct?
I think it has to do with how humid you make your house. And it reminded me of the time that when I was a new physician and I was telling my friends, humidifier, pour it on. You need to make your house just...
It's more comfortable.
Yeah, you don't want to have dry, cracked noses and get colds from this. And so when you have a humid house, what happens, Tom?
Well, you develop dust mites, and I want to thank you very much for recommending that to your patients.
That was wrong.
Okay.
Gave you some business, baby.
Yeah.
Well, I was sharing with Rick an interesting story, and that is in England, which is a lot more humid than here, they tend to take the covers of their bed and fold them back so they don't trap their moisture after they, in other words, after they've slept in the bed.
Turn down the linens.
Turn down the linen instead of pulling them up like we do, because that traps the moisture, which allows a microenvironment for your dust mite to live in. And of course, you've provided plenty of protein support with your skin cells.
Yeah.
So they love your pillow and your mattress, and that's why the treatment that works the best is just allergen barriers, you know, microfiber that doesn't allow the dust mite to get into the mattress. And that would save you the money from being on nasal steroids and antihistamines and that kind of thing.
And you let the humidity out by pulling up the sheets and
pulling them back, right?
I mean, pulling them back and letting the sheets air.
Yeah, pretty simple.
Let your bed air. Right. And you have a scratchy voice. Is this a virus or an allergy, Tom?
This is yelling and having a lot of fun with my siblings and their kids, and a little bit of a cold.
Okay, all right.
Not an allergy.
This sounds quite interesting, but we got questions
we
already.
need to hear about the party and the yelling with your siblings, but that's another time.
We have a caller from Del Rapids, 73-year-old female. Why, at age 73, is she having an allergy problem?
Yeah, now people, most of the time, kids, you know, they get their, 6, 7, 8, 9, 10, 11, they get into an allergic thing, the asthma type of thing. You get allergies as a young adult, and then they dwindle. Normally, they diminish as you get older, right? I mean, isn't that...
You're right. You're absolutely correct.
So this is a 73-year-old person.
So that's why we have to figure out, is it really allergic? Because age brings on a very similar problem called chronic non-allergic rhinitis. We used to call it vasomotor rhinitis.
Yes.
And chronic non-allergic rhinitis is due to the normal inhibitory pathways deteriorate as we age, and so your nose just becomes a drippy nose.
Okay,
for no allergy and no good reason. It's just
well,
the
now
way
irritants will stimulate your nose, like smelling bleach or chlorine in a pool or strong odors, and that can cause drippiness. But these people walk around with a Kleenex inside of their sleeve, and they're dabbing their nose, and the characteristic is that the mucus from an allergic phenomenon tends to be thicker and stickier, and that from vasomotor rhinitis is drippier.
So this lady probably has a drippier thing.
Could have. There are a few people that develop allergy in the geriatric age group, but it is the exception rather than the rule. And almost all of them that develop this have big family histories and had allergic disease before, because there's a hereditary portion to it.
Let's take the opposite of that. There are people who, as they get older, they get no mucus, they get no drainage, they get dry mouth, dry nose, dry. Why am I so dry, doctor? What can I have? What pill can you give? And I can take away pills that might bring it on. Particularly the worst culprit is the urinary spasm pills that, they just dry people out, you know. I mean, but does an allergy have anything to do with dry?
No, that again is, and I actually measure in the eye, a thing called a Schirmer's test, which shows how much tearing you have, which is directly related to how much nasal mucus you make and how much mucus you're going to make in the back of your throat. So you just do dry out, particularly with age, and particularly in a dry climate. And the treatment is topical salt water, which is cheap and easy.
Salt nasal spray and suck on a lemon drop, sugar-free lemon drop.
Sugar-free.
I want to ask about this Schirmer's test. Now, is this like some horrible, painful thing where you like poke at my eye, or?
Well, I actually put a piece of paper in your eye, and you
That's
produce tears, and the paper progressively shows how much tearing you have. If it's under 10, you have a dry eye, and if it's over 10, you have a normal or not dry eye.
That doesn't sound too bad.
No, you take. I used to say you would do this blotted paper that you would use in the lab, and you'd cut into strips and you'd bend it and put it in your. But now, obviously, there's a registered linear standard Schirmer's test instead of using this this laboratory paper.
Okay.
So, good.
Question from Castlewood, a gentleman age 45. He has ringing in the ears, and is it possible that it could be related to an allergy? He takes antihistamine. There's a constant ringing, sometimes goes away. It says fluid behind ears. So there may be.
Well, you know, this is kind of an ears, nose, and throat answer, and I know he's going to have an answer, but I'm going to give my shot at it, and that is that ringing of the ears is most commonly neurosensory hearing loss. And so you have that from too much noise in your lifetime, farming or sawing or hammering too many hours, or you inherited this sensory neural loss, and that's the majority of it. And no amount of pills or drying out the will help. Now there are some problems with the middle ear where there's mucus back there that's caught that won't help things and needs to be addressed, but that's probably not the answer to his ringing. Now, what's your answer to that, Tom?
Absolutely true. And the thing is that it would be a subset of already allergic people that have all kinds of other symptoms. They're sneezing and they're itching and they're congested, and that congestion sometimes makes that tinnitus or ringing worse.
Worse, yeah. And but the majority of the time, there's not much to do for it.
Okay. Well, that's kind of
you turn on the radio, get off the channel, and you go to sleep with this. Or you buy a wave machine. You know, you can hear the waves coming in.
The white noise kind of helps.
The white noise helps.
Okay. A 32-year-old gentleman calling from Brookings. He has allergy headaches that are more painful than migraines. He's tried numerous antihistamines. The headaches can be on either side of the center of the head, so the eye area, either right or left. What can he do for help?
Nasal congestion headaches, Tom. Take your shot.
Aren't those great? I mean, they are tough.
No, they're not any fun.
They are tough. So what I try to do is to try to differentiate the headache that actually is from nasal congestion from the migraine headache. And some of the differentiating factors you just talked about, is the one I like best, if there's just a single one, is throbbing. Throbbing headache, I tend to go towards the migraine. Non-throbbing, I tend to go towards the nasal congestion. And actually, if they come in my office with that symptom, I'll decongest their nose and see how much relief they get just from local decongestant. And sometimes that tells you, because if it's a migraine, it ain't going to help any. And then, of course, you could also administer a migraine medication and see if that makes a difference. Right. But when he says the antihistamine doesn't work, I'm just telling me it's probably a migraine and something.
And I honestly believe that many or some people's migraines are triggered by several different things, but certainly congestion is one of them, and cold times of the year and maybe are more sensitive. I remember in my 40s, early 40s, I had a period of time when I would go on down to Cook's Kitchen early morning, and I would have a headache that would just be throbbing, and it would be over one eye, and I thought, oh, the sinus is really pounding. It's the sinus. It wasn't. It's a migraine variant triggered by congestion.
Right.
Yeah. Exactly. And a steroid nasal spray solved the problem.
Okay. Now, changing, still on the topic of sinus headaches, what about spraying saline up your nose or the neti pots
or steroid nasal sprays? Let's talk about what can people over the counter do, and then compare it to steroid nasal sprays for congestion or for, what about neti pots?
I really like using salt water. Now, neti pot has an overwhelming amount of volume to it, so not everybody can use a neti pot. And so they have different systems to deliver it, including, I've got people who just sniff it up from their hand. It's whatever system works for you. I have a syringe that's designed to atomize. That works well. Lower volume, about 5 cc's. A neti pot actually comes out the other side. There's so much volume.
Well, and pressure. And when you do it,
Boy, so
I've done the neti pot, and you dip it up, and then it just fills it just lots of
pressure. You're drowning.
And it makes me worried about that as a real always safe deal. Some people do just fine with it, but washing out the crap that's in the nasal mucosa is a good idea.
Well, saline's a little decongestant itself, and if it's a little hypertonic, it'll actually decongest, but you have to be careful. A lot of the
hypertonic, for those of us
hypertonic means that there's more salt in it than just normally found in your nose. Isotonic means it's the same.
It's salt water if it's isotonic. It's the same as our body, so it doesn't draw fluid in, it doesn't put fluid out. It's neutral. If you do water, that's hypotonic. It doesn't have this, and it will put water into the tissue and congest it. If you do extra salt, it'll draw it out and dry it out. Am I wrong? Did I get that turned around?
You got it just right.
Okay.
I'm sorry.
So are you suggesting that we do a hypertonic saline solution, or do you like the...
I like the isotonic, but you can cheat just a little bit, put a little pinch of salt in your isotonic solution, which comes as usually about a liter bottle.
Can you buy those?
Yes.
Just buy a bottle of isotonic saline, sterile saline.
Yep, exactly.
Cheapest way to do it. I mean, there are these places where you can put this. It brings you powder and you mix it and so on and so forth.
Those are nice because they're buffered and that kind of thing, but you know, you can make it with non-iodized salt. I wouldn't use any with iodine in it. It's irritating, which is sea salt.
Yeah.
And they're formulas that you can find on the internet. It's basically about 1/8 of a teaspoon and 4 ounces of water. But
okay.
The problem, you know, it's the same idea of gargling with salt water. Now, when I grew up, my dad had learned to gargle with salt water. So he would take a cup and he'd put about 1/4 of the cup full of salt.
Really salty.
And then he'd fill the rest up with hot water. So this is hypertonic
and would suck
saline.
the life out of his
It would just dry everything.
Exactly.
And I thought, ooh, this is weird. And then of course, your pressure.
But it will really take the soreness out because those pain fibers, you've basically sucked the life out of them. Yeah, exactly.
Well, now I always have this question in mind. Good home remedies and bad home remedies. Now,
so the good home remedy is a teaspoon per gallon. You know, I mean, if there are 2 teaspoons per gallon is isotonic saline. So it doesn't take a lot of salt to make that a normal tonic, salt water saline solution. So don't do this hypertonic, too much salt.
If you always want to do it right, the pharmacist has salt water, not normal saline for all the stuff he does right behind the counter.
Right, and it's fairly
just
cheap.
Salt water, and it's inexpensive.
Okay. A question from Selby, a female caller, age 89. She's allergic more or less to all antibiotics. What else can she use? Are there natural remedies? Now, so let's talk about allergy.
Ooh, that brings a great topic.
To drugs.
Well, now this guy brought this to me. I think you were on the show like 4 years ago, and we were talking probiotic. I remember after the show we went over to my house and we were sitting on the back porch talking about antibiotics and overuse of antibiotics, and you started talking probiotics. And I went, just a little bit on the edge of homeopathy, and I thought, nah, come on, Tom. And that year, an article came out in the Lancet talking about using what is that yogurt? That
lactobacillus.
Yeah,
acidophilus.
But this particular type of yogurt that is probiotic, that is sold. I can't remember the name of it, but anyway, that Jamie Lee Curtis advertised. Activa, and they showed on this article that it prevented the overgrowth problems that commonly follow antibiotics. And I thought, well, I don't know if that's going to be important, except at the next American College of Physicians meeting, I heard it repeated 3 times by 3 different experts, one in infectious disease, one in general medicine, and another in allergy. So I think there's something to it. What do you think about the probiotics for preventing overgrowth problems?
That's when I take an antibiotic, it throws off, it kills the bacteria in my gut, and then I get diarrhea. So
that's another example of it, but it's also,
Exactly. Well, you guys are right on line. The antibiotic does change the bacterial flora that you have in your gut, and you have a very delicate relationship. You have more bacteria in your gut than you have cells in your body. And the GI guys, thank you. The GI guys are
growing,
exactly,
massing an attack.
And you have a relationship with those bacteria that's very positive. And when it's negative, then you start seeing some issues with your gut and some compromise in your gut function. Now, do we know exactly what's going on? No. Largest immune organ in the body, don't know what's exactly going on. But we do know that 2 probiotic things, Bifidobacillus and Lactobacillus rhamnosus, are both really good, helpful bacteria, particularly in these episodes for bacterial overgrowth. Now, this lady's talking about antibiotic allergy. First thing I do when they come to the office, I take a very careful history, because many of the people do not have an allergy. They have an intolerance or a side effect, which we can overcome. Erythromycin, related to zithromax,
azithromycin or erythromycin. It stimulates the gut, and we even use it for people whose stomachs won't empty. It stimulates the gut to move.
So they get stomach aches. Well, if you take it with food, which doesn't do anything with the absorption, you may reduce that side effect. So that's not an allergy. And you may even have enough stomach ache to throw up. I mean, that can be that. The most common one is a rash with penicillin. Fine rash all the way over, not very itchy, a little bit, but not too bad. It's called a penicillin rash, not allergic. It's more of an interface between what that antibiotic's doing with all that bacteria in your body.
The bacteria numbers are dropping, the cells are released into the system, and the body reacts to the reduction of the breakdown products of the dead bacteria. You're right, that fine rash. Not the urticaria. Urticaria is an allergic reaction. If you get urticaria with penicillin, you don't want to mess with it.
What is urticaria?
Urticaria, hives.
Okay.
You get hives.
And sometimes in my office I'll listen carefully to what they say, and the process they got the antibiotic for, like strep, produces a rash, and so it has its own rash. Or they have hiving, but they're not a very allergic individual. I'll challenge them in the office with penicillin
and see if
they react.
How do you challenge them safely?
Well, that's by doing a really good history, and so that you're pretty sure. We've got a blood test that is okay if it's positive. We've got some skin testing, a thing called pre-pen, which is a pretty darn good skin test material to identify IgE-mediated significant penicillin allergy.
Right. And of course, so what we'd do is with this lady is to find out if she really is allergic to everything. I want one more quick question before we need to take a break.
She should see an allergist.
She needs to see a guy like Luzier. Okay. The question, Tom, is that recently a patient was told by the pharmacist that they couldn't take Kefalex or cephalexin or one of the cephalosporins because she was so allergic to penicillin. It scared her, and so she didn't. What's your comment about that cross-reaction?
Well, if you read the literature, evidence, it's quoted anywhere from about 4% to maybe the highest of 15%. So that's not a very big risk.
Cross-reaction.
Cross-reactivity. And if we're talking with the penicillin anaphylaxis, that's the systemic reaction,
it's dangerous,
really dangerous, there you raise your eyebrows on the cephalosporin. I can't remember the last anaphylaxis I've seen for penicillin, which used to be with the old shots. Yeah. So I don't see anaphylaxis with penicillin, and if I don't see anaphylaxis, I'm not overly concerned with the cephalosporin cross-reactivity.
Okay. All right, we'll let you rest your voices for a second. Go back to tape. You may already know that a type of immunotherapy, better known as allergy shots, is a common way to treat allergies. And On Call met with a man who takes allergy shots on a regular basis to learn about this. Dustin Walker waited long enough suffering from allergies. He moved to South Dakota in 2001, and that's when his allergy problems started.
I didn't have any allergies previous to that in California, but I started noticing I was getting stuffy quite a bit, excessively congested, and really that continued on for 7 years. I've taken just your regular cephedrine and other decongestants and antihistamines, and just didn't really seem to do anything about it. Didn't help, so I just quit taking that and just said, oh well, that's just the way it's going to be.
Pollen from the grasses and trees of South Dakota summers made Walker especially miserable. Nasal congestion interfered with his sleep, and even in winter, he was tired, stuffed up, and unable to breathe properly. Finally, his wife suggested he make an appointment with a physician who had specialized training in treating allergies. And after undergoing allergy tests, shots were recommended for Walker.
Okay, Dustin. Left arm first for the pollens.
Okay.
And it's given sub-Q.
It's better you don't anyway.
That's 0.5. Then we do the other arm. There you go.
That's it. Pretty simple. I'm just really glad that I was recommended to an allergist because I would have never known to do that, and it's certainly helped my life since then.
Pollen allergy affects about 1 out of 10 Americans.
Thank you for joining us tonight. Our show is about understanding allergies, and here in the studio ready to answer your questions are Dr. Thomas Luzier and the on-call medical editor, Dr. Rick Holm. Our phone lines are open, and you can call in right now with your questions about our topic tonight. Our phone number is 1-888-376-6225. Yeah.
Is that the right number?
No, 376-6225. What did I say? I don't know. Look on the screen. I apologize. Yes, I apologize. We have a question from Sturgis, who got through before I mangled the phone number. A lady, 62 years old. She does not have allergies. Every morning after breakfast, though, she has intense sneezing. Could it be allergies? She has yogurt, granola, and coffee. Anyway, the only time of the day that she has the sneezing is in the morning after breakfast.
Sneezing is an interesting reaction. I mean, it's sort of like a knee jerk. If you hit the knee with the reflex hammer right at the right spot, the knee will bounce out.
Fling out.
There, you can take a little baby and push the baby's legs down on the table, and the baby will actually walk. It's an amazing thing that'll happen. And then if you have a person look at a bright light, sometimes they'll sneeze. If you put something in their ear, they'll sneeze. Talk to us about sneezing, Dr.
Sneezing's kind of the cough of the upper airway, because your airway feels like it needs to clear something. But there's receptors in your nose. And so this phenomenon we see here is we do see people, they get up in the morning, they have accumulated a little mucus in their upper airway by pooling. So they're up and around, they're on their same schedule, they eat, usually on a pretty tight schedule, I eat the same thing, and that eating is another stimulus of the upper airway, because obviously you're stimulating your nose for taste and smell.
Yeah.
And so I see this phenomenon of eating and sneezing, particularly in the morning, just as a reflex. Now, if you have vasomotor rhinitis, 62 years old, my age group, you can have that added to there and get a little more of that sneezing phenomenon. So I don't think it's allergic, because she didn't describe anything else going on. It didn't persist. My throat didn't close. So I don't think she's allergic to the yogurt or the granola or
whatever
the coffee.
The coffee, yeah. No, it's just it's a reflex in the morning.
All right. Question from Mitchell. Female caller has no sense of smell and very little taste. What kind of doctor should she go to find out?
A very good one.
Is this a complicated problem?
The problem, I mean, you know, of course, I think that Dr. Luzier is the perfect person to go to when you've lost all that, because many times there are some things that you can do to reduce all that inflammatory and oftentimes allergic and sometimes mechanical irritation. But a lot of times people lose their taste and their smell, and it's sort of like their hearing as they get older, and it just kind of goes away, and you don't have don't have it like you had when you were younger. Now, am I incorrect?
No, you are right on the money.
Okay.
And of course, what I do in the office when I have somebody come in with hypoosmia, I can't smell very well, and hypogeusia, I can't taste, is I examine them carefully. Listen to their history, examine them carefully, look in their nose and make sure they don't have polyps, which would obstruct their ability to smell, and that's an inflammatory, the ultimate inflammatory response in their nose. Make sure they haven't had a significant injury to their nose, because if I'll ask, well, did you break your nose? And you know, the nose is shifted way over like this. Well, that can be a problem, mechanical, which you just described. And then if it looks like a fairly normal nose, I'm looking at that their family loses their sense of smell and taste with age. Sometimes I'll give them a short course of steroid and see if they get an instant improvement in their nasal, their smell, and their taste. And then I'll be tempted to use a topical nasal steroid to try to make that better. It will not restore it.
Yeah. And you know, it used to be that for all the world everybody said zinc. And I mean, we did zinc for, I don't know how many people with bad smellers I gave zinc, and I had zero reaction to it. I mean, it didn't make a difference. It was just one of those, the word was out that it was zinc. And now we know that there is a zinc thing that you can put in your nose for a cold that destroys your smell.
Oh, really?
So that you want to avoid the zinc treatment for cold.
Destroys it forever?
Well,
or just
I don't know. Do you know, Tom?
No, I don't know. I read some of those articles, and I really didn't.
Yeah.
I kind of got the impression that somebody who uses zinc all the time, not just for a cold, and I did never notice the concentration. I think that's a little kind of a tough area. So they ask, what kind of doctor do you see? Your primary care may be very astute in this area. ENTs manage this all the time, and they're excellent at recognizing structural abnormalities, because the most common one is your septum is pushed over, and then I take care of the medical part. I like.
On a rare occasion, there's something involving the cranial nerve that comes down from the top with little horse hairs that distribute to the nasal mucosa. So there could be something in the brain, but I don't even want to say that, because everybody goes immediately for the $4,000 expensive test, and it will almost always be normal. The CAT scan of the head or the MRI is going to be normal.
Start with my regular doctor and
do the simple things first, and know full well that the chances are good that you're not going to have a good result. I mean, it's just one of those things that.
Okay. One of the benefits of getting older and seeing another sunrise.
Yeah, that's right. You're alive.
Yeah. Okay.
That's right.
A question from Clear Lake, 89-year-old female. For the past 5 years, she's had horrible allergies, a horrible allergy cough. She takes Singulair. It does not seem to help. What else can she do?
Singulair has not been in my list of favorite drugs, and most of the data has not really been very favorable for Singulair. I think, let's just see what Dr. Luzier says. You probably like Singulair better than I do.
But I don't see the general population. I see allergic people whose cells secrete a lot of cystinyl leukotrienes, which is a fancy name for one of those products that's of the allergy phenomenon from the mast cell. So I get a little better improvement with Singulair. Singulair actually has a group of people that are responders, half responders, and non-responders.
Yeah.
That is a genetic receptor issue. So I have people that
you try it,
respond.
and if it doesn't make a lot of difference, forget it.
That's exactly my advice. Now, and again, we're looking at chronic cough in an 89-year-old. That has a wonderful workup with it. I mean, there's a great evaluation. They could be refluxing. It could be from postnasal drip. We would try to determine that.
So it could be stomach acid, could be postnasal drip.
Postnasal drip. It could be something in the lung,
Could be the ACE inhibitor that she's getting for her blood pressure.
Excellent.
And or an ARB. You know, the lisinopril is the ACE inhibitor, or maybe the losartan, which is the ARB. They can all cause coughs, and many of the other medicines can, and maybe heart failure can cause it. But I think, as Tom says, the big ones are the nasal drainage and the reflux in the night. That's the other big.
But 89, the ACE inhibitor cough is just like what she's describing, just intense.
Make sure that you aren't on a prill of some kind. And the other thing is, I get a person who has a persistent cough, they better have a chest x-ray. See what's going on in there.
Okay. A question from Sioux Falls, 54-year-old female, wondering if there are any foods or vitamins that are helpful when you have allergies.
Ooh, vitamins, supplements. What do you recommend for people who have allergies?
Nothing specifically. Now, there's some interesting data on vitamin D in people who are in the northern climates, because vitamin D has a lot of dependent pathways that are immune. And particularly with airway reactivity and asthma.
Really?
There's some information that hadn't really coalesced, because this is the new zinc.
Yeah, everybody is, wow,
right. But we do have a lot of deficiency in the northern climate, and we know there are a lot of vitamin D dependent pathways. So I do think vitamin D is something worth looking at. Well, the great thing is the serum test is cheap and easy, and so we can actually look at that. I think exercise, eating right, just common sense things make allergic disease less. If you're on a lot of antibiotic, we were just talking about this, it may make your gut not tolerate things like lactose in milk and that sort of thing. So there's some phenomena that occur that can make you kind of have allergy symptoms, but it's just because you've had some other phenomenon, a very bad upper respiratory infection like respiratory syncytial virus, that kind of gets allergy things going.
I think it's the careful history. You know, it's not that CAT scan or that very expensive test. It's this careful history that really gives you the clue. And at 89, I really worry about polypharmacy. I think so many people are on too many medicines, and all of us should be asking our doctor, do we need to have all those medicines, doctor? One got started by this doctor, and another got started by that doctor, and I need you, my main guy, my main gal, to look at those and see if we can cut back some of these.
That's a good point, the polypharmacy
Polypharmacy,
stuff.
you know, one of those pills might be the culprit.
Okay. Two questions that are sort of similar. A caller from Sioux Falls, a gentleman, age 69, was diagnosed as allergic to penicillin years ago. Not sure if he can take it again. Has that worn off? And a question from a female caller from Alpena. Husband is 55 years old, had strep throat, put on amoxicillin after 5 days, broke out with a rash on thighs, no reaction to the medicine before. So
there's going to be an allergic reaction to a medicine never happens the first time. There's got to be a sensitizing time. It's the second or the third or the fourth, and then finally, now you've got an allergy to it. And now, and that's what it is. You don't have an allergic reaction to a bee sting the first time. It's that second or the third time. So it could be that that's developed now.
Does it ever wear off? I mean, if I was allergic...
The answer to your question is does it wear off? Yes. Yeah, it can. But again, careful history. Not very many people are allergic to these antibiotics. That's mediated through a special pathway, IgE, and they've usually had to receive a fair amount of it. It's usually IM that does the sensitizing, injections. So in both of these cases, I would be suspect. Remember, I got it for strep throat. What did I just say about strep throat? Strep has its own rash that goes along with it.
But would you use penicillin in that person who had a rash 5 days after his penicillin?
I might. I mean, if that was the drug of choice, you called me on the phone and said, Tom, this guy's got to have penicillin. He has got endocarditis.
Yeah, he's got the type that, you know.
So I'd listen to the history. If I thought that he was at high risk, I would orally desensitize him. I'd start with a small dose and just keep building up until he was ready to have the IV dose.
Let's talk a little bit about desensitization. You know, so you just talked about giving them a little penicillin for an allergy to penicillin. In other words, you start low and you kind of build up on it. If I have an allergy to cat dander, you give me a little cat dander and then a little bit higher dose and a little bit higher dose. What is that all about?
It's a great question. It's probably the hottest thing in allergy right now. The standard of care is the typical allergy shot that you saw received there. And we're giving you what you're allergic to. That's why it's in the office and you have risk of having a systemic allergic reaction, bad reaction, because we're giving you what you're allergic to. But as you give it, you develop a thing that's immunologically is called tolerance. And as you tolerate it, you actually create an antibody situation which changes the cells that are responsible. So it is, or potentially, is a cure or a long-term remission. Now we're getting a lot of information about the oral desensitization, like I just told you with penicillin, by mouth. It's just not ready for prime time. They're doing it for peanut and milk and grass.
And penicillin.
And penicillin. Penicillin is an older kind of
oral
phenomenon. Okay. Oral, and then we give it IV, that kind of thing.
Not ready for prime time. What does that mean?
We just haven't put enough evidence together to show the right dose, what's going to be most cost effective, that kind of thing.
But there are really people who are, I mean, there's doctors that are giving them right and left. I mean, there's some people out of Wisconsin, I think, or whatever, that are really pushing this and it's making a lot of money, but you are saying that it's not quite ready. The data is coming along, but you wouldn't say it's something that you would do right now.
I wouldn't, and I looked at it seriously with my colleagues here in this state because it take care of a lot of problems that we have, having to go to the doctor's office, all that kind of thing. The shot, I mean, it's a complex kind of thing. But you don't want to be initiating therapy that the general community of evidence says, oh, it's just not ready for prime time.
We haven't proven it yet.
This is that whole first do no harm thing that you guys
or don't just do it because it makes money. Now, I mean, I'm not pointing my fingers at, there's some really good people who are doing that. They're in a different ballpark. It's just that my opinion is that when I've heard several allergists say, not yet, I'm there. Now, I mean, we probably could bring on an expert who would say, oh, it's a thing to do. So it also says to you that we don't completely agree in everything in this
and the debate would end up being maybe 60-40 in my favor, maybe 50-50, because they make a very good point, and I hope they're right. But it's a lot of the studies are for one antigen. So few people just have one. There's a desensitization oral for grass pollen.
Yeah.
Excellent. Used in Europe. It's a pill. I can't wait for it to be available, but I don't have very many people that are just grass pollen allergic. They're allergic to a wide number of trees, weeds.
Okay. All right. I like this question. A gentleman from Sioux Falls, age 52. He's allergic to canned peas and would like to have that explained. Why would you have it?
Canned peas? I have no idea. I wonder if it's if you can take frozen peas but not canned peas, maybe it's something in the metal, a low or a
I wonder if they sulfite
preservative
in canned peas.
That may well be it, because what about the sulfite? You know, there are a lot of people.
I'd love to work that guy up. Okay, go ahead. Okay, that's a great question. I can't eat canned peas. Now, of course, avoiding canned peas might be something.
Yeah, I was thinking.
But that's
a great. Just not to eat.
Because since they're frozen, that's a great question. Sulfiting.
Let's talk about sulfiting. People go to salad bars and they get sick. Now, tell us about that.
Sulfite, which actually in our environment now is mostly seen in trail mix, so that it'll look pretty. So because if you take an apricot and you don't sulfite it, it turns brown when you dry it. So it's not very pretty. So they sulfite the stuff in trail mix. And the sulfite, you eat it.
How about meat, dried meat sticks?
Dried meat sticks may have sulfiting agent. They may have nitrating agents in them. Some of them are just smoked. Right. You know, and don't have anything in them. They're just smoked.
Okay.
So, but the sulfiting, and it'll say contains sulfites on the labeling, unless you're getting something, you know, that's not standard. Somebody's making in their backyard. But the sulfiting agent is an oxidizer, so it makes it look pretty. I mean, it doesn't, or fails to make it oxidize. So it interacts with the hydrogen chloride in your stomach and forms hydrogen sulfide, which is breathed in and tends to make people wheezy, and some people, and make them itch, and sometimes makes them swell.
So and people do use
mostly wheezy.
Okay, so people get wheezy when they get the sulfites, and you did see a lot of them on the salad bars to keep their lettuce.
Right, and they're not supposed to do that anymore.
Right, they're
no sulfites. And the other one was they used to soak potatoes so that they wouldn't turn brown.
Yeah.
In sulfiting agent.
Yeah.
I mean, they're not supposed to be doing that anymore.
Okay.
All right.
There you go.
Well, we've got about a minute left. The time has flown by. You got any final words of wisdom that you want the audience to know about?
Well, I think the most important thing in allergic disease is, and one of the things we look at is first thing is go to an allergist, identify your allergic disease, use your primary care as a person to do the sorting out. They do a great job. I get great referrals. And then once we've found out, remember that avoidance is still one of the better ones. Keep your windows closed, that kind of thing. Before you go to a lot of medications, we were talking about being thrilled about over-counter medications being available that were prescription before. I think that's a fabulous thing to happen, because now they're inexpensive. Before they were expensive.
Well, and what a joy to have you here. Wonderful information. We've covered the gamut today. It's been a fun topic.
Great.
Thanks so much.
Thank
Gentlemen, thank you so much. Viewers, stay tuned. We're going to have a quick break, and then we'll be back with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Every spring through summer, I expect a call from a patient of mine after he's had an exposure to poison ivy. Like 80% of the population, when he touches the plant, he breaks out with a miserable, blistery, and itchy skin reaction. But my friend is so allergic to poison ivy that he jokes he gets a rash if he even dreams he's gone camping. In this area of the country, poison ivy is a very common weed, as it crops up around lakes and streams and on the edges of wooded areas. Normally there are 3 green or red almond-shaped leaves. The side leaflets sometimes have a notch. The middle leaf has a long stem. Stems are hairy without thorns, and there can be a small cluster of green or white berries. This might be a freestanding shrub, a trailing ground plant, or come from a ropey-like woody, hairy vine which climbs trees. Remember, leaves of 3, let it be. Berries white, run in fright, and hairy vine, no friend of mine. The rash is an allergic reaction humans have from the oil or sap that comes off the fine hairs on the stems, the leaves, and the woody vines, the latter of which remain a threat even through the winter. Once exposed to the oil, there is less than 15 minutes to remove it before harm is done. Antiseptic rubbing alcohol towelettes are effective, readily available, and cheap. Then rinse with cold water, followed by a dish detergent cleansing in lukewarm water. Hot water too early can spread the toxin. Finally, wipe down shoes with rubbing alcohol. Wash your clothes, and if the dog got into it, someone not so allergic should wash the dog. Usually 12 to 48 hours after exposure, the allergic skin reaction is a linear, very itchy, blistery rash, which may worsen over days or weeks if not treated. Know that the fluid from blisters, it's not toxic. Treatment includes laying on of cool, moist washcloths, followed by a topical calamine lotion or over-the-counter cortisone cream, and if bad enough, see your doctor for a prednisone prescription. So, if you are dreaming of a camping trip, know what plant to avoid, bring alcohol towelettes, and call the doctor if you get that darn rash. We'll be right back.
In our medical news tonight, pancreatic cancer is a rough diagnosis. It is very much a killer, in part because it is rarely found early. Right now, more than 94% of Americans diagnosed with pancreatic cancer die within 5 years of diagnosis. This is why scientists at the Mayo Clinic are studying ways to more effectively screen for pancreatic cancer. And in a recent study, they may have made some headway. Researchers targeted in on stool samples. Stool sample tests are non-invasive, and they have already shown the ability to assist in detecting colon cancer. There's a certain kind of DNA that's associated with colon cancers and precancers that often shows up in the stool or bowel movements of individuals with this disease. Scientists wanted to see if this was true regarding if what was true regarding colon cancer also turned out to be true in the case of pancreatic cancer. A group of 127 patients, 60 with pancreatic cancer and 67 without, allowed their stool samples to be tested for a recent study. The Mayo Clinic researchers found DNA markers that indicated pancreatic cancer in 70% of the patients who had this type of cancer. This means that 70% of the time their stool sample test got it right. Now, 70% identified means 30% not identified, and this method of screening is still in development, but it offers hope for a better way of identifying a truly life-threatening disease. And in other news, next week we're going to bring you a show about vascular disease. We'll talk about the circulatory system, your veins and arteries, and learn about what's in those pipes. We had to tape this show a while back, but we've added some updated content, and the information that we're going to share with you couldn't be more timely due to the fact that May is National Stroke Awareness Month. And on that note, we're just about out of time. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guest, Dr. Thomas Luzier, and our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to all of you for watching and calling in this evening. Have a good night.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by on-call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Biocommunications at South Dakota State University.